protection of our patients' health information. That helps.
Yes, Dr. Sinha. Yeah, thank you.
Thank you, Chris. I'm assistant professor here, just after a few months ago. Chris,
Welcome to UC San Diego.
thank you. Chris, one of the challenges that I see is the length of these prompts as well as the answers. Did you get a chance to work on this new LLMs that are like more tuned? For example, you can have a few hundred responses from the doctor itself and have like a more shorter, similar tones that the doctor prefer instead of these really long responses.
Yeah, so just paraphrasing the question, it's about there's a lot of new large language models, or exploring the answer is absolutely yes. And the expert is Dr. Karndeep Singh, who will tell you in some more detail about that. But we're watching closely on MedPom and Llama and these other LLMs. I think there's a lot of promise there. What we're using here is in partnership with Epic and Microsoft, it's GPT-4, right? And so, yeah, we can get shorter responses just by tuning the prompt, right? But in some ways that's a gold standard. What it is not a gold standard for is cost. And that's really concerning to me as somebody who's closely watching the budget. And so another area that we're actively exploring is AI scribes, right? The ambient listening. And in fact, while this pilot isn't showing a time savings on answering patient messages, if you read the study published in the New England Journal Catalyst last week about the scribe pilot at Kaiser in 3,000 physicians and 300,000 patient encounters, it clearly is saving clinicians time. And so the documentation assistance that AI can provide is great. The challenge is that the Microsoft Nuance product is unaffordable for an enterprise. We could do 20 or 50 or 100 doctors. We couldn't afford every physician. And so I'm very excited about some of these new large language models. And as you probably know well, there's even some now that are highly tuned and can run locally without even requiring a cloud compute, which is astounding to me. You can run a LLM on your laptop computer. But I think that those are going to be critically important because we don't need GPT-4 to do AI scribing, in an exam room with a restricted lexicon. We do need an affordable large language model that's not going to increase the cost of healthcare across the U.S.
So, I guess with all of this data, in fact, whatever you put in other words, garbage in, you get garbage out. What do you do on the part of the patients and getting information from them and get their compliance, et cetera? What kind of motivation is it for the patients?
Maybe you can give me a little bit more color on your question. What are you asking about with patients? Like,
you're getting data from patients, and is it real? Is it fake? I know I take my blood pressure way too frequently.
Yeah.
And what's going to make me do it better?
Yeah. So great questions, and there's, as you know, sort of a whole field around patient engagement and digital health and consent and other things. So maybe just kind of a few high-level comments. One is in our remote patient monitoring program, I talked about P1000, P10,000. Something that our team may talk a little bit more about is that our patient response has been overwhelmingly positive. They really appreciate that the clinicians are engaged in helping them kind of co-manage. And so a lot of patients are doing wearables, they're measuring things at home, but they're not sharing it with their clinicians. And that kind of loop, to be able to close the loop, I think is really important. Are we getting fake data from patients? I don't think we're getting it intentionally. Is our data in the electronic health record dirty? Absolutely. I mean, lots of studies have showed, for example, I used to have this great slide about growth charts. And, there's all the normal kind of range of, height and weight. And then there are these string beans where somebody had fat fingered a decimal point and people were, 100 feet tall or something like that. Or, weighed 0.1 pounds. And so there's always going to be dirty data in real world kind of data sets in the electronic health record. But we have strategies for excluding, those type of data, particularly as we're building models. In terms of patient consent, this is a really important area. And something Dr. Rob Elcari here will likely talk about.
Compliance, not consent.
Compliance. So if you're talking about compliance with sort of outpatient medication regimens and measurement, things like that, those are always challenges, and I think Heidi's going to talk about user and patient-centered design and how we're approaching that.
Wonderful.
Thank you, Vish.
Thank you, Chris, for kicking this off. Now we are going to get a little deeper dive. Along the way, I also want to introduce a few of our guests here. So Dan, he asked a question already. Dan is a venture capitalist at a company called Flare Capital. Again, they're very active on the East Coast, and we are trying to make them active here in San Diego as well. So thank you for being here. Okay. And a number of you are back from last year. Thank you for being back again. So we are off to a good start here. So the next step is going to be a deeper dive into what Chris presented, the CHI and some of the projects from CHI. One of our key partners is Jeff Pan, who is helpful in curating this and getting this going. Unfortunately, Jeff fell sick this week, but our colleagues at CHI have stepped in to take this forward. Dr. Karandeep Singh, whose name was mentioned by Chris a couple of times already earlier today, has just arrived. He's our new Chief Health AI Officer, or AI Health Officer, I hope I'm saying it right, joining from the University of Michigan, and also famous for his study on the sepsis algorithms that Chris alluded to. And Karandeep is going to give a more deeper picture later this afternoon on looking at the opportunities and challenges of AI algorithms. But this morning, he's going to step in and lead the CHI presentations. So I'm going to turn it to our CHI team, Nicole, Heidi, and Karandeep. And I'm having, I messaged you, I don't know if you got it.
I just saw your message.
Okay.
We'll pull up.
Yeah, so feel free to just get some coffee. We're going to, the presentation that was mailed to me, I have difficulty accessing it. We're going to get that going. But get some coffee and get to know your colleagues who are here as well.
It's Zoom, just YouTube, and all that stuff. But that might be easier.
Thank you.
When we get out,
I'll be around. I want to talk to you about I got this as a gift. It was a holiday gift. I haven't used it. Probably.
Editors of the
Your regular use? Yeah. Okay, good morning. We're ready to go. Hope you got some coffee here to get yourself going. Good morning. We're ready to go back. Could you please get back? We are ready to get going with our colleagues from the Jacob Center for Health Innovation. So, as I told you, can you help them move in? Just guide them in. Okay. Thank you for joining us again. So last year when we did this, it was literally a one-day event. So we went through a lot of talks back to back. And one of the feedback we got was a little deeper dive into some of the content. Okay, so we're doing that this time. So after Chris's talk, we are now joined by our colleagues from the Jacob Center for Health Innovation. And who's not here is Jeff Pan, who has been working with me for the last month or so in curating this. Unfortunately, he fell sick at the last minute. But very graciously, Dr. Karandeep Singh, who's just joining us at UCSD as to lead all these AI efforts, he's going to be orchestrating the session here for us. And he's joined by Jacob Center colleagues, Nicole and Heidi. Right? So Nicole here and Heidi. So are you going to introduce this, Nicole? Yeah, Nicole, Peter.
Yeah, I'll introduce it. Can everyone hear me?
Yeah.
Great. Yep. I'm Nicole May, co-director of the Center for Health Innovation with Jeff, who unfortunately couldn't be here, joined by Dr. Singh, who is our Chief AI Officer and the Jacobs Endowed Chair for Digital Health, along with Heidi Rataj, who is our Program Director for Design and Strategy. And actually, once a week, sits upstairs here in this building, working with students in the design lab. Okay, so just to go a little bit further on Chris's description of the purpose of the Jacobs Center, we definitely take to heart innovation at scale with impact. That's in the center of what we do. We hope to lead the way in digital health innovation through the development and implementation of technologies that make people's lives better. We also really take heart that concept of the bridge. We believe that we are the bridge that can help bring technologies from campus and from industry, from our own patients to implement in the health system. And we really take that to heart and hope to be putting out and extending a hand to all of you to be working with us as we try to improve healthcare for all of our patients. And lastly, our principles are based on the quintuple aim. improve the patient experience, improve health outcomes, improve health cost of care, address health equity, and improve the provider experience. Again, that bridge, we are collaborating with so many folks on campus and hope, again, to extend that collaboration to everyone in this room. The point is that we cannot do real true innovation at scale with impact without collaborating with all of you every single day. In terms of our areas of focus, we really think about 3 technology gardens: mobile health applications, AI and machine learning, and the implementation or integration of things with our electronic medical record. Alongside that comes services and standards. So again, with Heidi kind of bringing that bridge for the design lab, really looking at digitally enabled human-centered service models to accompany those mobile health applications, ethical and secure practices for AI and machine learning, and industry interoperability standards. These are the areas of focus right now. This could change over time as maybe AI becomes commonplace in about 10 years. These will change. Again, we're always trying to stay at the forefront of innovation in healthcare. We take it very seriously, human-centered design and co-design. This actually is one of the students that's working with us on the student mental health app that Heidi will describe in a second, but we do follow those design principles, the double diamond, really trying to ensure that the patient experience, the human experience is at the center of everything we do. Otherwise, our health technologies won't work in the places that we're intending them to be. So three things that we wanted to just dig into a little bit today are 3 projects or 3 areas that we happen to be working on. One is the crisis of mental health in young adults. Heidi will be describing our work on a student mental health app, hoping to solve not only this crisis for young adults, but how it's kind of spilling over into the way that we're delivering care with our own staff. How can we use this project to not only affect healthcare with our students, but how can we then expand it and use the knowledge and information that we're gathering from this project to affect our staff, our healthcare workers, our frontline workers. Dr. Singh will talk about the untapped potential of unstructured health data and how we're using AI and large language models to really improve patient quality and experience in the healthcare system. And lastly, talk a little bit more about the mission control project that Chris mentioned earlier, how we're using mission control to coordinate care from hospital to home, to the clinic, to back again, really creating this seamless environment of care for our patients and our providers. So let me turn it over to Heidi.
Do a little dance. Thank you.
You had the microphone, everything goes.
A little closer. I could do a rap with this. So good morning. I am really feel very honored and grateful to be here. And one of the reasons is that I love co-designing and I love working with students. So the opportunity that was afforded by the state of California to really lean into this decided challenge, not only for young people, but for everyone. We, the challenge of anxiety and depression and suicidality was known pre-COVID. It certainly was exacerbated during COVID. And our young people were removed, were displaced, were finding and searching and looking for ways in which to connect. And so the opportunity for students to come back to campus and be able to now lean into how might we co-design together to really try to solve that problem together. So as I mentioned, with the state of California, they also took this very seriously and gave us an opportunity whereby we might be able to address this challenge. And for us, we were really leaning into this how might we statement. How might we co-create with students to create a digital resource, a solution, something that could be applied for this campus and hopefully beyond. We decided, of course, with human-centered design, it always starts with going where the people are, talking to students, engaging with students, doing surveys, but also talking with our providers, our stakeholders, those that are delivering this type of really gorgeous, beautiful services throughout the campus. And Discovery One, which was a course of deep dive interviews with our providers and our students, really some of the highlights that came from that was that, of course, it's very much a challenge for a young person to come to any new institution. They're losing their network. Sometimes the family dynamics are quite different. Sometimes they have to take a leadership role. Sometimes they feel lost. This is what we found also consistent in our research. We also, when talking with our providers, there was this replication that we saw in the data, which was a demand was outstripping the supply for this one-on-one therapy, the ability to be able to provide these type of therapies for our student body. A very strong desire for a simplification of the system. And Paul here, my colleague at the design lab, really called that out, is that there's a tremendous amount of things that are going on this campus all the time. How do you find it? How do you find the right thing at the right time? And now how do you find it if you're really stressed, or if you're feeling that level of anxiety, or you're feeling alone? So they also discovered that there was a challenge of communication. There's, again, a lot of things going on with outreach, but not really being able to measure that. Is the tabling working? Is the presentations that I'm co-doing with my deans working? Are the group therapy kinds of activities working? We decided to then lean in a little bit further. And so the Discovery 2 really represents our effort to co-design. And what I mean by that is daily, student-led. They're with me every single hour that I'm able to do and work with them, because they also have classes. These students are amazing. They're diverse. They have complications. They think big. These students are cognitive science students. They are machine learning students. They're public health students. We wanted that diversity because we knew we wanted to try to lean into that level of the kind of diversity that we were hoping to solve for, international students and transfers. We held and put together a survey. Again, the students put that survey together. We were able to reach 300 students over the summer. And part of what we wanted to learn, not only how the CAP services were received, which I want to say were generally really good. No surprise to me, because I know how amazing our healthcare providers are here on campus doing the daily work of supporting our students. But we also wanted to understand what the appetite might be as we wanted to explore the additional technologies that we wanted to build into the app. Passive sensing, active sensing. And what our students were sharing with us already is that their appetite was pretty favorable for some of these things that are already out there commonly used. Sleep, activity, mood. Some of the things that weren't quite ready, and which we all also understand, we know there's a lot of possibility for, GPS screen time. We want to go where the user is. We want to go where the user is ready. So these are things that are important as we develop our app. The other things we wanted to really, again, call from Discovery 1 and 2 was that, again, this reluctance for students to find the services, that full spectrum of technologies, and that students were saying that, whether they're a transfer or a freshman, that they're being told about too many things at that moment, right? And I don't know if you guys all know about orientation, but there's just so much information going on, and it's an overload. It's too much for them. And as a consequence, that part where they had actually ranked their mental health and well-being lower than their academics, there's, again, this mismatch, right? I don't know, I can't find it, and so on. And finally, we just wanted to call out from our stakeholders too, they're doing a lot of manual labor. There's a lot of work going on, from scheduling to following up, from spending time with our students on the phone to explain what CAPS is and what it's not, how the insurance works, how registration works. A lot of effort is going on, which is tremendous. How might we try to solve for that as well? So we devised a problem statement, again, just to showcase what I've just shared with you. Navigating the balance between mental health and well-being and academics is challenging. Further complicated by a lack of awareness regarding availability of the resources and the modes of engagement. So what we're looking to do, and we're now past that design phase, now working with our developers, is to build a free app, a platform, if you want to think about it that way, offering personalized mental health and wellness resources that promote this self-care journey, this holistic expression. When you're leaving your home and you're coming here, there's a tremendous amount of pressure to realign your efforts right away. And we want to be able to look hard at that and be able to bring you resources that are right there. We're also looking at ways in which we can gamify our solution, looking at ways in how we can continue to develop engagement through incentives so that we can reduce the reliance on that immediate one-on-one therapy that we were able to identify in our research with our students. This idea of like, I'm waiting, oh no, I gotta call somebody. And that frustration because there needs to be an assessment, there needs to be an evaluation. You're speaking with a clinical psychologist on the other side of that phone who wants to listen, who needs to make sure that they put you in the right place at the appropriate time. So our app focused first on this first version, which we're planning to launch September, fall of 2024. Is built on a recommendation engine. So many of you know Netflix, Spotify, big fan of Spotify, with an aggregation. So again, why not bring all of these terrific resources and services together in one place? And why not, in which we're developing, use a recommendation engine based on the onboarding, the preferences, the things that the students have identified that they're initially interested in, and serve those up immediately. Over time, how might we then continue to build out our AI model with implicit, explicit, using an a priori framework whereby we can understand those relationships and continue to give you more, but maybe other things too where you can discover. Maybe other elements that you might want to lean into a little bit further. Maybe ways in which when we correlate, we start to show students how worrying about your finances exasperates your anxiety. Worrying about your roommate who's not cleaning themselves up when they're in the same room might actually contribute to your stress. Thinking about ways in which we might use EMAs and push notifications whereby we can support you right before that test or the night before, or encourage you afterwards because that box breathing actually did work. And did you notice that not only you felt maybe a little better when you took the test, but you actually improved that score? These are opportunities that we see that will be a part of this app. The other is that this is a digital front door. So this app will be connected to your MyChart. We think that's important because it gives us an opportunity to teach you about healthcare early, the importance of that dialogue and patient portal. When we talk about our digital front door, we use this narrative that the MyChart, the business of doing healthcare, will stay in MyChart. Your labs, your x-rays, your private communication between provider and patient remains in MyChart. Where we're trying to simplify and help our providers is the ability to book online, the ability to be reminded, the ability for a push notification that currently doesn't exist, so that we can encourage that student who has been identified through that brief telephone assessment, through that evaluation, to continue to nudge, to continue to support that student to get the therapy that they need. A dashboard always comes with an app. We're going to be leaning into, and I wish I could announce now, we're close about the ways in which we want to express this dashboard. So soon to come, keep following us. Also an avatar, which I wish I could share a little bit more about, but really the nature of using gamification, the ability to lean into your personal experience so that as you learn, you're learning with your avatar. And again, we have been spending a lot of time on bringing together that comprehensive resource directory to which I alluded earlier. Future features, just checking our time, is goal tracking. Of course, the ability to extend into and learn about yourself and lean into the wellness ecosystem that's here available at UCSD, goal tracking makes sense, right? How might I move towards a new place of my discovery? Really leaning into some of the design construct of what we know very consistently with the wellness wheel. What are the elements that I can learn about myself? What are the elements that give me joy? What are the elements that allow me to continue to succeed? Based on what you want. This is user-driven. We are not a clinical diagnostic. You can ask anybody in the providers that we've talked to as well. The student makes the choice together with their providers on the next step and the next step. Incentives, we've been very, very lucky to already be reaching out to a number of groups here in terms of the workshops that are available, recreation. We're going to be working towards that as well, so more to come. And as I mentioned, passive sensing and active sensing, we want to be able to bring in those third-party integrations so that you can learn more about yourself. Again, all opt-in with the ability to correlate both health analytics and your holistic self-care journey. And finally, I'm just checking on time, is it's been lovely to work, as I said, in this environment and work with my colleagues. We're really interested in connectedness. We're interested in things that are sound already in this universe of mental health and wellness, and we're calling out through this trusted network. We know people do better when I say, I would like to have Nicole and Karandeep a part of my trusted network, so they know what's going on with me, so I can lean on them and they can lean on me. If Karandeep could check in and like, hey Heidi, I've noticed you haven't gone to yoga for a bit. Are you okay? We know this works from all of my work in diabetes, the Follow app, the ability for you to have a trusted network to continue to support you because managing diabetes is difficult. Managing your chronic stress is difficult. Managing the world of college is difficult. And why not have people that you can trust to look after you, to lean in and support you? I'm going to move it to my colleagues soon, but just want to share that we're very excited. We're launching 2024. There's more to come. And most importantly, this is student-led. There are many logos and things I loved that gets pushed to the side. I am not the target audience, but I get to work with them every day. So thank you so much for your time.
Thank you. Hi everyone, sorry I was a little bit late to come. I was hoping to catch the morning and then spent 45 minutes late for morning, but I was able to make it here. My name is Karandeep Singh. I'm relatively new to campus. We're kind of in the process of moving over from Michigan, so I'll be here for good kind of this summer, but in the meantime, we'll be making trips, so hope to meet individually with many of you. I'll be talking about some of our initiatives around generative AI, and we'll talk a little bit in detail around a couple of them, but still at a high level, just given that we're trying to, at this point, introduce you to some of the key concepts, and happy to chat afterwards about like specific LLMs and things like that. So, as you know, most of the information that we care about in healthcare is not sitting in structured data. We've known this for a while, and I've known this better than most because I've worked with a lot of the bespoke natural language processing tools that are out there to try to get important data out of the electronic health record. But the truth is that even though we've had so many different tools available when it comes to things like text, a lot of them have just not been production grade quality. They're things that I think are great for research. They're just not things that we could ever really rely on to even get in the ballpark of something that would actually even help a clinician or help someone who's staff do their job faster, better, more productively. So I think there's a big change now with generative AI and the fact that there's now one unifying general concept that lets us approach these things through a couple of different mechanisms, taking advantage of generative AI. We have a large amount of data. I don't think we're unique in this at UC San Diego Health in that there are a lot of large health centers, but just to say that if you look at the largest available kind of national structured data studies, we're way bigger than that. And so that means we have an opportunity to learn from our patient population, learn from every patient. And it also means we have a diverse population that we can learn from because our network actually isn't just in San Diego, but is across the region. So it used to be the case that if you were working with text data, image data, speech data, that people were talking about different kinds of deep learning architectures. And more recently, there's been really kind of a harmonization where a lot of people now are using transformers, and transformers is now the architecture that you can use to work with all these different kinds of data. And what that essentially means is that whereas before you had to have different people with different levels of expertise and different skill sets to work with these kinds of data, now actually you can have people with multimodal expertise who can do this kind of work with kind of individual frameworks that previously only touched one or two of these kinds of elements. So where's our work going in generative AI? Well, first and foremost, our work is going into making sure we have access to the data, and especially access to our multimodal data. Without that, there's really not much that we can do. Text is a big part of that, but imaging is also a part of that. Pathology is a part of that. And I think down the road on our roadmap is to consider multi-omics data, because we know genomics may be a part of that, and epigenetics and so on. We're thinking a lot about data flows. And this is a really busy diagram. The really key thing here is there's not one way to train a model and deploy a model. And what that means is that even if someone comes to us with working Python code that's been pressure tested on our data, on our patients, it takes us a while to figure out how to get that integrated into our electronic health record where we can actually use it and study it. Our Python to patient time is too long. And so I'm trying to figure out, in terms of our data flows, how can we figure out the easiest, most reproducible way to get data into models to patients? In the space of generative AI specifically, in June, before I joined UC San Diego, there was a generative AI town hall where a lot of ideas were solicited. I think over 100 ideas were submitted by the faculty. The idea here is we're not the experts in what the needs are. We want our faculty to surface the needs. And so there were faculty and staff who surfaced not just clinical needs, but actually a lot of non-clinical needs focused on things like process efficiency and patient experience. And out of these, we ended up selecting 10 idea wave projects to work on. Projects that kind of touch on different things. And a handful of these are things that we may end up partnering with vendors to work on. But a lot of these are things that we're trying to figure out, how are we going to run open large language models on that data behind our firewall, teach our clinicians a little bit of prompt engineering so that we can start with the zero-shot learning approaches, go to few-shot learning, kind of work up the complexity level. So we start simple, and then if simple doesn't work, then we try some of the more complicated ways of deploying these kinds of things. My hope is that if we can get out of the box open large language models working, then we have a path to do all kinds of information extraction that before was really difficult, if not impossible to do, even with these kind of bespoke tools. We also selected 5 projects that are driven by health system leadership priorities. So things like discharge barriers, health equity, length of stay. And these are things that, if you pitched as a research proposal, they would say, that's been done. People have looked at that. There's just no way to do that. And I think the idea here is that's the thing the health system cares about. Let's try to actually take the best of breed technology and apply it to the things that actually matter when it comes to delivering better healthcare. One of the things I'll just highlight is we're going to be doing a randomized study of a couple of different ambient scribing technologies. This is where we haven't built the technology. We're partnering with a couple of vendors, but we're not just going to roll them out. We're going to actually study both quantitatively and qualitatively how well do these things actually work in speeding up people's ability to do notes effectively, the quality of the notes themselves, and also what is the cognitive burden of the people doing the work, because we know burnout's a big problem, and we're trying to get to that issue as well. And we're partnering with the other UCs, so this is not happening kind of only here. We're looking at, from a health system perspective, this kind of Project Greco idea, where we think about different ways we might use large language models at a system level to do different things. So we might use it to support health system decision-making, things like, what decision could we take now that would help us serve our patients better in a specific way? I mean, we have a lot of data, we have a lot of dashboards, we have a lot of smart people, but there's a lot of things you can do to kind of supplement that with large language model-based information, especially if you can pair that with something called retrieval augmented generation, which is take high quality, information, pair it with large language models, and get out something that actually is potentially useful to decision makers. And then we want ones that can serve our patients, one that can serve kind of community decision making, things that will address social determinants of health. And so these are kind of big concepts that we're thinking about as more long-term things to try to tackle. So like an example of something that would be a health system one is, have a specific co-pilot for each of our healthcare leaders that helps them think about the impacts of various decisions they might make. And then we are not going to delegate any of that decision-making to an AI model, but the idea being, we want to see if this can help us arrive at better decisions. We know that there's a lot of technical debt, so a lot of the things we're thinking about is infrastructure. We have 10 different pilots, which is great. 10 different pilots is too many. The only way we can do 10 different pilots is if we identify some level of shared principles and infrastructure to execute on all 10 pilots, and then that will hopefully let us be able to do the next 10 pilots and the next 10. So I think we're really trying to figure out not just what's the fastest way to do it. The fastest way to do it is open up chat.openai.com and type it into GPT-4. That's not what we want. What we want is what's the way that we can do it that will let us do it again and again and again. Obviously, we're thinking about integrating all this into the electronic health record when it makes sense to do so. So that's kind of something we're constantly thinking about. Again, is with the idea, we want it to last. Things that live outside of the electronic health record targeted to clinicians, they don't last. So we're focusing on kind of stickiness and trying to see if we can get that integration working. Right now, we're kind of in the middle of this maturity model path. So we've started with some kind of very operational back office type things when it comes to AI. We're kind of touching on some minimal impact things where, you know, if things don't go right, there's really not much harm done. And then there's some areas where we're focusing on really high impact things. And so you may have seen, you know, last week there was a paper showing that our sepsis model deployed at UC San Diego is relatively reducing mortality and an absolute reduction in mortality. Those are the kinds of things we want to be able to support starting in 2024. And then the key thing for me is we got to educate our clinicians and educate our data scientists. And we want to make sure folks who are doing really good data science work on campus have a way to do that data science work in health. So we've got some data science handbooks we're developing, not to teach data science, but to teach the right data scientists how they can work in our environments, how they can, you know, find that lowest hanging way to do both model development, model training, and model evaluation, and model deployment. So with that, I'll turn it over to Nicole to talk about mission control.
So mission control brings together the things that Heidi and Karndeep have mentioned already. This is the manifestation of AI on mobile, a co-pilot for patients, AI models that are enabling decision making. This is where all of these projects sort of come together in an overarching implementation within the health system for high impact outcomes. I need to mention, first of all, that mission control could only be possible with the Jacobs gift. And really the focus of the Jacobs gift was not only on kind of providing the seed funding for the center, but also to provide the seed funding for mission control as a space. It includes our innovation labs over at Town Center and the Med Campus, mission control itself, which will be located in Jacobs Medical Center, and UBAR, which is a patient-facing digital service experience within the hospital and in the outpatient space. So these three spaces make up mission control, and they will all work together seamlessly. Mission control itself will manifest as a physical command center in the Jacobs Medical Center. So the first piece of it is really this physical space. But now that we have 4 hospitals and we have tons of outpatient clinics, this will really be the command center, not only for mission control in the Jacobs Medical Center, but will also be orchestrating patient care throughout our health system and with patients at home. So virtual and physical space are being taken into account. Analytics and AI underpin the mission control, as Dr. Singh just mentioned. All of these models that are looking at efficiency, are looking at quality of care, ensuring that we're making the best decisions, they will manifest in mission control with the folks on the ground who are orchestrating patient flow through our hospital. And lastly, tech and automation. So we're also hoping to make the burden of providing care easier. How can we leverage computer vision? How can we leverage ambient listening? How can we use technologies that we already have, like the EMR, in different and unique ways to make things more efficient? Like Chris mentioned earlier with AI-assisted messaging. all sorts of things that we can do to make the process of care more efficient and automated for our healthcare providers. So what does this look like? Initially this space that's mission controlled in Jacobs Medical Center is about 1,000 square feet. A typical command, this is not going to be your typical command center, in that, again, we hope to be monitoring what's going on in the outpatient space along with the inpatient space. You know, it would be really cool if a patient using one of our mobile apps and have this co-pilot in their pocket and is part of our P10,000 program digitally monitored, that information was coming into mission control and we could predict what was going to happen before they even needed care in the hospital. How can we help them in the place that they are living and working and avoid that hospital admission, right? So that is the dream of mission control, is that we're not only working with the patients in our physical space, but we're predicting and preventing things that could happen at home. And so there's that two-way communication with the patients and the providers. We also want to make sure that there's an innovation space here in mission control so that we are looking at the way things are flowing with the providers, the way that the data is coming in, the way that they're interacting with data that we're always trying to improve upon mission control and make it better. This could manifest in many ways. Mission control could be your classic NASA style command center where you've got screens on the walls and everybody's kind of looking at their computer. Or maybe it could be a place where you're interacting with data in real time in 3D. Heidi's brought together several folks who are looking at how do you do data visualization in a more interesting way, where you're not just looking at a screen, but you're actually interacting with it as a group, maybe as a group of people together and virtually, just as an example. And so that's why this space is interesting. We, of course, could put people in a co-located room with screens today, but we want to take that a step further. There's a lot of effort going on in our health system right now. As Chris mentioned, we are bursting at the seams. It's hard to find beds for patients. We're growing and purchasing hospitals to solve some of this problem, but we're hoping that with mission control, as we're doing performance improvement efforts all along the way to make patient flow, make the provision of care more efficient, these technologies in this mission control space and everything associated with this project is kind of giving a boost so that we're going from one curve of performance improvement to something that's much, much bigger. And lastly, just to circle back to what Karin was talking about, underlying all of this are going to be those prediction models and that ability to really get ahead of the data and use data in a more real-time, impactful way right there at the bedside and even at home. So that's that. Thank you so much. And do we have time for questions?
Yeah.
Okay.
Thanks, Nicole, Carly, and Haley. We have time for a few questions here before we move on to our next panel. Any questions, comments here? We have a mic. The gentleman over there in the back?
Yeah, my name is Kumar Kavoli. I'm an undergraduate at UCSD. This is more directed to the wellness app. I was actually curious on why you decided to create like a whole new app instead of integrating it into the UCSD app. Was there a specific reason for that, or?
Yeah, it's a great question. You can hear me too. Initially, we didn't want to create an app. I think it was really the conversation of sort of a platform. As we were directed more and more by the research from the students, we recognized that we really needed to create two things. We needed an ability to aggregate everything that had to do with wellness and mental health. And we needed a recommendation engine to be able to serve those up and make those suggestions. That currently doesn't exist. We also didn't want to take away from the students' experience with other apps that are currently working. Really the idea, the focus for us is we want you to, as a student, think about, when you think about wellness and mental health, we want you to think about this particular app that gives you access to all the other apps and services and resources that currently exist in one place. We have got a lot of interest for others to potentially come and work with us and vice versa. So as we learn from the user and learn how the user is using those resources and services, we're always in the collaboration business. So we need to start, and that was one of the reasons we're starting here.
Thank you.
Hi, my name is Alma Lazo. I'm one of the hospitals at CSD. I work with some students who are interested in creating AI algorithms for clinical use. And the crux of their issue is that they want to have augmented retrieval generation in their AI algorithm. To be able to access, for instance, only up-to-date as an answer source for the algorithm queries, are there avenues within CHI that they could develop these initiatives, or do they have to go to AI, or do they have to go to the proprietary owners of these databases to do that?
Yeah, so that's a great question. Feel free to connect them with me. The issue with using up-to-date is that up-to-date's license may not allow us to use up-to-date in that way. So the first thing you do when you use retrieval augmented generation is you convert all the text into a vector representation, right, called a vector store, and then you query it in a database. And so, I mean, it's kind of funny because on one hand, large language models wouldn't exist if they had followed those rules. But I think, you know, for us to be able to query those kinds of resources, we would probably need to figure out licensing. I know UpToDate for sure is working on their own retrieval augmented generation. I don't know if they will be working on an API that will let others plug into it. But that said, there are definitely resources and papers on PubMed that have the appropriate licensing that, like, you can pull certain kinds of stuff in. So I wouldn't let that not being able to do it up to date kind of stop them from prototyping in other ways. So I'd be happy to connect. The piece on our end, which is we're still figuring out, is how would we support augmented generation on our end? You know, we work with Amazon. Amazon has their own tools, but we're not trying to use their proprietary LLM. We're trying to work with open LLMs. And so there's a lot of different toolkits. We're just trying to figure out what's the one that is kind of the easiest one for a variety of different users with different levels of expertise.
Hi, my name is Ajay Bharti. I'm an infectious disease physician here. It's wonderful to hear about all these innovative things to improve patient experience, outcomes, and efficiency in the system. One of the things that may be beyond the panel's sort of scope is if we reduce hospitalization and interaction with the hospital or healthcare system, how do we pay for it? What is supporting all of this? And I see this a lot in my field, because a lot of what we do prevents hospitalization, prevents surgeries, prevents complications, and there's no money for it. And so, just to give an example, a liver transplant may cost $1 million, and a lot of players get paid through that. Treating liver hepatitis C that causes cirrhosis and liver cancer or requires liver transplantation doesn't generate any of that, but doesn't get a fraction of that back. So just a thought.
I can share initial thoughts and I'll hand it over to Nicole. My initial thought would be, yes, the incentives are often misaligned. If a patient develops sepsis in the hospital, we may actually make more money off that patient, even though that's something that we're trying to avoid. And something that we're trying to treat, even if the cause of the sepsis was something iatrogenic and something that was, you know, like a catheter-associated UTI. So I think same is true for patients where we take on the risk. For patients where we take on the risk, you know, in those patients, doing more might actually cause us to lose money. And so if we do more for those patients, you can have the opposite effect where, you know, we end up losing money. So I think, yes, the from a hospital and healthcare standpoint, we're thinking about as things that we target, what is the ROI to the health system? Because I think this is not a research project. This is not about grants. This is about fixing healthcare problems. And, you know, so if it's going to bring in ROI, it's going to improve quality of care. Those are both things that are important that I think are worth talking about. But I would say those are health system level type decisions, and that we're not going to be guided simply by this will potentially cause some money to get lost if it will result in better care. But I think we're working, because it's a Jacobs Center for Health Innovation is based out of the health system. We're working at the service of the health system and trying to make care better and meet the needs of the health system.
Yeah, and just one more thing. I mean, I think Dr. Longhurst mentioned we had to delay outpatient surgeries this month because we already have so many patients boarding in the ED. Like, our prediction model is showing that we need to pull patients off the schedule, right? So I think what we benefit from here in San Diego is that we have far more demand than supply right now. And I think that's what we're trying to do here, is how can we leverage these technologies and these tools to free up some of that so that we can get the patients who really need a liver transplant in. And the other point is that some of these tools are going to help us with things like nursing shortage, right? Like, if we could do virtual nursing and we can have paid co-pilots and people kind of getting care in different settings, we might be able to kind of alleviate some of the pressure we're feeling on the staffing side as well. And those are just a couple of examples of where I think the economics still make sense, just because we have kind of these demand and supply mismatches.
Thank you. I think that, Dr. Jay, you asked a terrific question, because as a society, and the whole world is now dealing with this issue, right? The emergence of AI and any technology for that matter. How are we going to pay for it? Especially the model of healthcare, as people have pointed out, is more sick care than wellness care. But you see value-based care starting to go up as well. And there are a number of you here who are involved in nonprofit initiatives and other initiatives to transform healthcare, which is actually our next module here. But it's actually a major question, and that's why we are bringing the whole university together. And hopefully that's a point that we'll discuss the rest of the 2 days. In fact, tomorrow we have a venture capitalist coming down from Silicon Valley, who was a practitioner, clinician who moved into venture capital, but really about cost savings and moving into value-based care. So hopefully you'll be able to join for that as well. Are there any other questions, or shall we go into a break yet, Abu? Yes.
Very short. So I was just looking through, so the article that you posted, with Arne Lucina as the first author on it. I chatted with Aaron a while ago, I don't remember if I asked this, but there's a value in measuring, and the more you measure, the more you discover. But one unintended consequence in this case is the more you predict sepsis, there's a high likelihood that you'll probably preemptively go in with antibiotics and the like. So is that a worrisome unintended consequence that we might be, going in the wrong direction of generating more and more, drug-resistant microbes and the like?
Yeah, so your question is about sepsis, and if we predict sepsis, might we overtreat sepsis? And actually what's interesting is a lot of the researchers in this space, like Chanu Ri, who do sepsis definitions, have looked at the issue of how changing sepsis definitions have changed people's practices. And probably we're in a phase now where a lot of people actually do get overtreated because they're trying to make sure that their sepsis bundle compliance measures they report to Medicare actually look good at the cost of some people getting kind of unnecessary antibiotics. So in that specific study, I can't speak to it because I wasn't directly involved in it, but that's actually questions when I was at Michigan that I asked Shamim Namadi, I asked Aaron Bucina, have you guys looked at this issue? I've asked colleagues at Case Metro Health. They published a study looking at better sepsis outcomes. Well, I said, how do you know they're better outcomes and not just new people getting diagnosed with borderline sepsis, which makes the outcomes look better, but it's not actually better? So I'll just say sepsis is a very complicated and circular set of definitions and treatments. We can chat more offline about it. But as far as I know, in my conversations with the authors of that study, they looked a lot at issues that would affect both expected and observed mortality. And it wasn't simply that they got better outcomes driven by different expected mortality, which is what you would expect if it was simply that you were overtreating people. The good news is that we're going to have one of the speakers this afternoon
is going to be from that sepsis team. So we're going to pick up on this topic a little bit more detail. But we do have, as Chris mentioned, one of the most advanced teams in this area that has just got published in Nature Digital Medicine, reporting clinical outcomes. So it's really fortunate that we have them here in San Diego. So let's take another brief break before we move to our pre-lunch team here, led by Ashley Gambier on transforming healthcare. Okay, so just get some coffee and be back in 5 minutes if you don't mind. Yeah, many thanks to our JCHM.